Hello everyone, I am Dr. Prashant, and in this presentation we will talk about primary hyperparathyroidism. Primary hyperparathyroidism is a generalized disorder of calcium, phosphate and bone metabolism with a prevalence of 1% and peak onset in the 3rd to 5th decade, characterized by increased secretion of parathyroid hormone resulting in increased calcium and reduced phosphate. The etiology of primary hyperparathyroidism is solitary adenoma of the parathyroid in 80% of the cases, but it could also be hereditary syndromes and multiple parathyroid tumors. Solitary adenoma of the parathyroid gland usually affects the inferior parathyroid gland, but it also may be present in the thymus, pericardium, or behind the esophagus. Histopathologically, chief cells predominate both in hyperplasia and adenoma. Parathyroid carcinoma is not an aggressive malignancy, but rarely may present with distant metastasis. Diagnosis is often made in retrospect, and levels of serum calcium, which may be 14 milligrams per deciliter or more, may be a clue. Hereditary syndromes and multiple parathyroid tumors, such as multiple endocrine neoplasia type 1, which is characterized by hyperparathyroidism, tumor of the pituitary and pancreas, and gastric hypersecretion, part of the Zollinger-Ellison syndrome, may be a cause. Similarly, multiple endocrine neoplasia type 2, which is characterized by hyperparathyroidism, pheochromocytoma, and medullary carcinoma of thyroid, may be present. Finally, hyperparathyroidism jaw tumor may be a cause, which is parathyroid tumors along with benign tumors of the jaw. Genetic considerations in primary hyperparathyroidism involves looking at the MEN1 gene, which encodes for the menin protein on chromosome 11. Biallelic loss of the function of this gene results in multiple endocrine neoplasia type 1. Therefore, it fits the definition for a tumor suppressor gene. Similarly, gene for multiple endocrine neoplasia type 2 is the RET proto-oncogene, and the gene for parathyroid cancer is the HRPT2 or CDC73. Additionally, retinoblastoma gene may also cause parathyroid cancer. Clinical features of hyperparathyroidism may range from asymptomatic to hypercalcemic parathyroid crisis. The latter is quite rare. The most common manifestations include renal and skeletal manifestations. The renal manifestations of hyperparathyroidism include recurrent nephrolithiasis, although this is seen only in less than 20% of the cases due to earlier detection. These stones are usually made of calcium oxalate or phosphate, and the patient may present with obstruction, infection, or end-stage renal disease. Skeletal manifestations of hyperparathyroidism was classically described to be Ascites fibrosa cystica, wherein giant multinucleated osteoclasts on the surface of the bone were seen. It was characterized by resorption of the phalangeal tufts and replacement of the usually sharp cortical outline of the bone in the digits by an irregular outline. This condition is rare in modern times due to earlier detection. Other clinical features of hyperparathyroidism could be in the gastrointestinal system, wherein there could be vague abdominal complaints and disorders of the pancreas. The patient could have cardiovascular disease characterized by left ventricular hypertrophy or endothelial dysfunction. Neurological manifestations would include subtle neuropsychiatric symptoms, and the patient could have joint pains indicating involvement of the musculoskeletal system. Asymptomatic primary hyperparathyroidism is monitored with serum calcium annually. Renal parameters such as eGFR are monitored annually. If the patient has kidney stones, then ultrasound or computed tomography of the kidney may be considered. Serum creatinine is also measured annually, and skeletal manifestations are also monitored every 1 to 2 years, either by X-ray or vertebral fracture assessment. The diagnosis of primary hyperparathyroidism is achieved by demonstrating an elevated PTH in a patient with hypercalcemia, and the gold standard for such a measurement are the PTH immunometric assays. The parathyroid hormone molecule contains an amino terminal and a carboxy terminal, and at present, second generation assays have antibodies against both these terminals. In the circulation, there may be a component of the parathyroid hormone which does not have the amino terminal. In the third generation assays, these are not registered and reported as parathyroid hormone, thereby increasing the accuracy of this test. The management of primary hyperparathyroidism is surgical, and there are two major approaches: the conventional neck exploration under general anesthesia, wherein a parathyroid gland is found. If it is enlarged, a normal one is sought. The next approach is the minimally invasive parathyroidectomy. In modern times, preoperative sestamibi scan with SPECT-based localization is increasingly popular. Intraoperative sampling of parathyroid hormone to look for a rapid fall is undertaken, and at present, preoperative sestamibi imaging, cervical block anesthesia, minimal surgical incision, and intraoperative parathyroid hormone measurements is the most popular approach. For patients with multiple gland hyperplasia, as may be seen in familial cases, there are two major approaches. The first is removal of 3 glands and partial excision of the 4th gland, or total parathyroidectomy with immediate transplantation of a portion of a removed, minced parathyroid gland into the muscles of the forearm may be undertaken. Surgery in asymptomatic patients may be considered if the patient is less than 50 years of age or has a serum calcium of more than 1 mg per deciliter above normal. If the patient has a creatinine clearance of less than 60, a 24-hour urinary calcium of more than 400 mg per day, or the presence of nephrolithiasis or nephrocalcinosis, surgery may be considered. Also, if the patient has a T-score of less than 2.5 at any of these sites, or a vertebral fracture by X-ray, CT or MRI, surgery may be considered. For patients having undergone surgery for primary hyperparathyroidism, we must remember that the serum calcium will decline in 24 hours and normalize in 3 to 4 days. Hypocalcemia is more likely if second or third explorations have been performed. Serum magnesium must be monitored and corrected whenever hypomagnesemia is detected. If the patient has low serum calcium along with Schwastek or Trojo's sign, parenteral calcium at a dose of 0.5 to 2 mg per kg per hour or 30 to 100 ml per hour of a 1 mg per ml solution is considered, followed by oral calcium and vitamin D analog replacement. That's it for our presentation on primary hyperparathyroidism. Thanks for watching, and we will see you in the next video.